Good evening, all the candidates present here. Today we have a session. It's actually a GI debriefing session, which will be taken by Dr. Asif Iqbal, sir, who is a HOD of Respiratory Critical Care and ECMO Services at Apollo Multispeciality Hospital, Kolkata. Also, if any aspirants have any queries regarding the registration of EDIC examination, you can ask at the end of the session. Thank you, sir. You may continue.
Yeah. Okay. So, student, 54-year-old lady want a history of severe gastric pain brought to the emergency department to evaluate thoroughly. Her past medical history is significantly for long-standing type 2 diabetes, hypertension, dyslipidemia, and she is on multiple medication. On examination, she's pyrexia, temperature 100.4 degree Fahrenheit. Her heart rate is 110 per minute, blood pressure 110 by 55, respiratory rate 28, oxygen saturation 98% on room air. Routine abdominal ultrasonography scan reveal gallbladder stone combined with bile duct diameter 8 mm, evidence of intraductal stone. Laboratory investigations showing that total count is high 18,000, hematocrit is high side 42, blood platelet count is 4,90,000, serum lipase is 8,000, serum calcium is 65, 6.5 milligram per dl, serum potassium 4.1, and serum blood urea nitrogen 65, creatinine is 2.5 per dl, and AST ALT is marginally high, alkaline phosphate is also high, serum bilirubin is 4.4, lactate is 3.2. She is admitted in the intensive care unit with suspected gallstone pancreatitis after 10 hours of treatment in the ICU. In spite of IV fluid resuscitation, IV broad spectrum antibiotic, her condition remarkably deteriorate with worsening pain, increased lactate from 3.2 to 4.4, and she's also developed hypotension. Which one of the following most pertinent next step of management for her condition? So you have an option continuous conservative management because the pancreatitis could worsen with endoscopic retrograde cholangiopancreatography ERCP, or consult surgery for the placement of the percutaneous transhepatic cholangiography tube, or consult nephrology for dialysis because her worsening clinical condition, consult gastroenterology team for urgent ERCP, and give IV fluid, which and switch antibiotic from piperacillin tazobactam to meropenem. So, for newcomers, in EDIC exam, there is a EDIC part 1 exam is a MCQ, but it has a two type MCQ. One is the K type question, while other is the A type question. A type question means the single best answer, and K type question means the true false. So you have to answer the every point whether true or false. Usually in the K-type question, the question stem is very shorter in a one-liner or maximum five-liner. But in A-type question, you might have a very long stem of the question. and you have to choose one of the option. So where is the problem? It is a gallstone pancreatitis case, and where the you have to tell about the what is the appropriate management single base answer. So you have an option. There are five options. So you have to choose the single base answer. Anyone? Yeah, you can give your answer in the chat box. So put your answer first, then we'll go for discussion. So anyone has given any answer? Yeah, let's see. So E. Give more IV fluid and switch antibiotic from piperacillin tazobactam. Mm. So here problem is the gallstone pancreatitis. So gallstone pancreatitis is something is that you have to clear the obstruction first because the bilirubin is getting high and patient is getting worsened. So first thing is the source control because sometime it is this due to obstruction causes the cholangitis, and so for the answer will be consult gastroenterology team for urgent endoscopic retrograde pancreatography. ERCP is the answer. Why? Because this lady gallstone pancreatitis associated with cholangitis and rapid deterioration because the total count is high and bilirubin is getting worse, and also the renal failure obviously is going worsening. But the main thing is that patient in a cholangitis, so you have to cure the obstruction fast. Then and switching antibiotic, we should provide adequate coverage less than 24-hour initiation. Not obtaining source control will not improve the condition. So only switching the antibiotic will not suffice. So, regarding the gallstone pancreatitis, the supportive care is fluid management, fluid resuscitation, early goal-directed therapy, or you can keep the MAP more than 75. So first, you consider as a when as you are dealing with a sepsis patient, so you first do fluid resuscitation and inotropic if require start inotropic support to maintain MAP, and always your approach should be ABC, airway, breathing, circulation, and oxygenation. You have to maintain the saturation more than 94%. And remember, in any sort of pancreatitis, early enteral feeding is recommended, either NG or NJ feeding, and avoid parenteral nutrition unless the enteral route is not tolerating. Then, okay. Then risk stratification for any pancreatitis. There are three scoring system you have to remember. One is the revised Atlanta classification, biceps, and the Apache 2. And if the persistent organ failure more than 48 hour in a severe, then it is a severe pancreatitis. Mortality is high. Role of antibiotic in pancreatitis not routinely required, but when there is a cholangitis or infective pancreatic necrosis, you have to give broad spectrum coverage. Like in this case, you have to give broad spectrum coverage. Piperacillin tazobactam was appropriate antibiotic. And ERCP indication for ERCP, acute cholangitis, yes, it is major indication. Persistent biliary obstruction suggested by rising bilirubin, dilated CVD, stone visualization, imaging, and worsening LFT. it is these are the indication for early ERCP. Not indication of ERCP if it is a mild pancreatitis with spontaneous stones passage or improved LFT, no cholangitis. So if there is a no cholangitis, LFT is okay, mild pancreatitis, you can wait for ERCP. And definitive management is cholecystectomy and ERCP followed by cholecystectomy. Moderate to severe pancreatitis case, you can delay cholecystectomy 6 to 8 weeks. Consider interval ERCP with sphincterotomy if surgery must be delayed. Management complication like pancreatic necrosis, pancreatic collection, and organ failure. This all about the management of the gallstone related pancreatitis. Now coming to your question number 11. 52-year-old gentleman assessed in the emergency department for fever, severe epigastric pain and nausea and worsening during the past 14 hours. He has no past medical history noted, but further questioning, he admit his mother has history of gallstone. On examination, he has pyrexia 101.8 degree Fahrenheit and his pulse rate is 110 beats per minute, blood pressure 100 by 65 mmHg, respiratory rate 20 breath per minute, oxygen saturation 94% on 2 liter moist oxygen via nasal cannula after blood is collected for laboratory testing. He is given 3 liter IV fluid ringer lactate over 3 hours. He is also given IV hydromorphone 1 milligram for pain management, vancomycin 1 milligram IV, cefepime 2 gram IV for control of his pyrexia. On urgent abdominal ultrasound scan suggests gallstone, gallbladder wall thickening, but it is also so pericholecystic fluid and dilated pancreatic drug. Pancreas appear inflamed, cystic, but no necrosis or not any cyst noted. Critical care service is consulted for severe pancreatitis. His vital sign after infusion of 3 liter crystalloid are reassess temperature 102 degree Fahrenheit, pulse rate 100, blood pressure still 110 by 78, respiratory rate 24 breath per minute, oxygen saturation 92% with 2 liter oxygen via nasal cannula, and the laboratory result is burn is 40, serum creatinine 0.84, serum aspartate amino transferase AST is 228, ALT is 125, serum amyl is 2000, bilirubin 2.6, lipase is 3470, total leukocyte count 12,000, hemoglobin is 15.5, hematocrit is 42.4, platelet count is 3000, 3,20,000, serum lactate is 3.8. Which one of the following proposition apply to the management of this gentleman condition? So your option is chest radiography may be helpful in determining his disease predict mortality at 30 day. Empiric antibiotics should be continued because they will decrease the risk of death. Further, IV fluid will decrease his risk of death. Immediate computed tomography CT scan with contrast will provide the most prognostic information. Initially, he should be given bowel rest because enteral feeding may worsen the prognosis. So, give your option. So, somebody given is A. Okay. Is it anyone? Yes. Let's see. So there is a variation of opinion. Let's see what answer is waiting for us. The chest radiography may be helpful for determining his disease predicted mortality at 30 days. Now I'm coming to explanation why. Because the question is for the question is here is the option. Which one of the following proposition applies to the management of gentleman condition? So it is a prognosticate scoring, the mortality scoring. And what are the mortality scoring is appropriate for acute pancreatitis? Most widely used scoring, one is the Apache 2 and the bedside index of severity of acute pancreatitis biceps scoring. And in the bicep scoring, if you see what are the variable, the bicep scoring variable is one of the one is BAN, 1 point. Impaired mental status GCS less than 15 is the 1 point. SARS criteria more than 2 is 1 point. Age more than 60 year 1 point, and the pleural effusion is the 1 point. And the interpretation of the risk factor 0 to 1 is the low risk, more than 3 is the severe acute pancreatitis, high mortality, and more than 4 is very high risk for mortality. So here, if you see the option, the chest radiograph is can identify the pleural effusion. Empiric antibiotics should be continued because they will decrease the risk of the death. In acute pancreatitis, there is no role of antibiotics unless there is a complication, necrosis or infected cyst, and further IV fluid will decrease his risk of death. No, if you give them liberal fluid in the pancreatitis, what will happen? It will cause the gut edema and will increase the intra-abdominal pressure. Immediate CT scan with contrast will provide most prognostic information. Immediate CT scan, there is no role. CT scan indicated after 48 hours if there is a persistent pain and the worsening of the condition, then the indication for the CT scan. And initially he should be given bowel rest because enteral feeding may worsen the prognosis. In recent evidence showing and says that if you enteral feed, you have to start within 48 hours. It prevents the translocation of the bacteria and improve mortality. So, what other Apache and the biceps is okay, but what other criteria for diagnosis mortality? One is the Ranson criteria, and other is the Glasgow Emery scoring system. That is also acceptable, and modified Marshall score for organ failure is currently gold standard. You have to know about the modified Marshall scoring. It has four parameter. One is the respiratory, PO2, FiO2, renal, the creatinine value, and the cardiovascular MAP versus vasopressure. And if the persistent organ failure more than 48 hours, it is a severe acute pancreatitis and high mortality. There are another score on the radiological score system, CT severity index, that is called Balthazar scoring system. and it is based on pancreatic inflammation and extent of necrosis. The score 0 to 10, 0 to 3 is the mild, 4 to 6 is the moderate, 7 to 10 is the severe. This in pancreatitis, there are a lot of score, but you have to know the biceps, Apache, modified Ranson, and Marshall score, and CBC, CT severity index. You will get MCQ from this area. So now coming to your question number 12. A 45-year-old lady examined in the emergency department for severe epigastric pain. Her clinical history and elevated level of serum lipase point toward diagnosis of acute pancreatitis. Routine review, systemic and other diagnostic workup are non-contributory. To meet the requirement of persistent fluid volume to maintain adequate mean arterial pressure, she is admitted to intensive care unit ICU. Regarding antimicrobial therapy for this lady, which may be following the best approach, your option is she should be given perioperative antibiotic only before surgery without another source of infection present. She should not give any antibiotic. She should be started empirically and broad spectrum antibiotic to prevent infection or necrotic pancreatitis. And she should be started empirically on antibiotic M only at anaerobes. So please give your answer. Yeah. কর্মদা, আমি একটা ক্লাস নিচ্ছি, আমি কি শেষ করে তোমাকে ফোন করি? হ্যাঁ, হ্যাঁ। So everybody is most of you are A and few of you are B. So she should be given perioperative antibiotic only before surgery, and B is without another source of infection present. She should not be given antibiotics. Okay. So let's see. So B is the correct answer. The without another source of infection present, she should not be given any antibiotics. So explanation, infection is the setting of severe acute pancreatitis is a worsen outcome. Unfortunately, administration of antibiotic to prevent complication is ineffective. Early antibiotic prophylaxis in this setting is controversial, but there is no data that support this practice. In the setting of infected pancreatitis, antibiotic typically aim gastrointestinal tract microbes should be given. The most studied class of antibiotic in this situation are carbapenem, which are typically given. There is no role of emergent surgery in this patient. So, what is the management of acute severe pancreatitis? First, initial management. So, initial management is hemodynamic stabilization, early aggressive fluid resuscitation. Preferable fluid is ringer lactate. Initial rate 5 to 10 ml per kg. Your target map will be 65, urine output 0.5 ml per kg, and lactate should be less than 2. Avoid over resuscitation, liberal fluid management. It will cause the abdominal compartment syndrome and worsening the ARDS. Analgesia, IV opioid is ideal, fentanyl or morphine. Paracetamol as adjunct. Epidural analgesia nowadays is maybe considered, but nowadays is not practiced. Oxygen and organ support. Your target SpO2 is 94%. Early ICU admission if persistent organ failure more than 48 hours. Shock, AKI, ARDS, or encephalopathy. If the indication for ICU admission question come, you have to utter these things. The persistent organ failure, shock, AKI, ARDS, encephalopathy. Nutritional support prefer early enteral nutrition and avoid routine parental nutrition. Etiology specific treatment, gallstone pancreatitis, urgent ERCP if cholangitis or persistent biliary obstruction, then followed by cholecystectomy if same admission if mild pancreatitis or delayed if severe disease. Alcohol-induced pancreatitis, alcohol cessation, thiamine supplementation. Hypertriglyceridemia is in insulin infusion and plasmapheresis if triglyceride level more than 1000 with organ failure. Antibiotic not to do, but if there is a cholangitis or infected necrosis or sepsis from extrapancreatic source, you have to give. Management of complication, necrotizing pancreatitis, conservative initially, and if infected necrosis, then percutaneous drainage, minimally invasive necrosectomy. You can do and delayed intervention, ideally more than 4 weeks, as per Penteral trial. Organ failure, AKI, CRRT, if indicated, ARDS, you have to go for the ARDS management, lung protective ventilation. If there is a persistent shock, then norepinephrine and vasopressin, your targeted MAP will be 75. Local complication, pseudocyst, observe if asymptomatic, drain if indicated. Severity stratification, you have a bicep score, Apache 2 or SOFA, or persistent organ failure, severe pancreatitis, modified Marshall's, and that is all about management of evidence-based management of pancreatitis. Now coming to question number 13. 51-year-old gentleman is admitted with acute pancreatitis. Which one of the following is the most effective plan to achieve adequate nutritional support for this gentleman? Total parenteral nutrition, prefers source of nutrition, but only after 7 days of bowel rest and inability to take anything by mouth. Enteral nutrition, prefers source for nutrition, but only after the 7 days of bowel rest. So option you are seeing, just give me answer. I think this is the right answer and everybody is correct. Now coming to the yes. Explanation. Already we have discussed that there is a lack of evidence support that historic practice of strict nothing per mount. When we are student, we used to learn that every senior consultant told us ki do not give do not give feed in a pancreatic patient. But subsequent evidence showing that the infused status reduce the flora, the good flora in the gut, and ultimately this breach of flora causing the translocation of the bacteria. Now coming to our 14th number question, that is 61-year-old gentleman with a history of hepatitis C, alcoholic cirrhosis, admitted to the ICU with emergency from the emergency department with suspected upper gastrointestinal bleeding. He has a history of esophageal varices, which require banding in the last year, and he was started on proton pump inhibitor and octreotide for him in the emergency department, and gastroenterology opinion was taken. No sooner than he is brought in the ICU is deteriorate with profuse hematemesis and the develop of hypotension. Upper endoscopy for source control is not available for at least 1 hour. In conjunction to continue resuscitation while waiting for the arrival of gastroenterology team, which one of the following is the most congruous management in this patient? Placement of Blackmore tube for hemorrhage control and stat antibiotic for spontaneous bacterial peritonitis prophylaxis, intubation for airway protection, and placement of Blackmore tube, hemorrhage control, and start antibiotic of SBP prophylaxis, placement nasogastric tube, start antibiotics, then start low dose beta blocker, decrease portal venous pressure, intubate the airway protection, and placement Blackmore tube, hemorrhage control. So B and D is more or less same option, only the antibiotics added for spontaneous bacterial peritonitis. So your answer, please. Yes. Yeah, good. Hmm. So maximum answer is D. I told you that there is a more similarity between B and D. So let's see the answer. So answer is B. Intubation of the airway protection, place Blackmore tube, hemorrhage control, and start antibiotic of SBP, the spontaneous bacterial peritonitis prophylaxis. Why? That if the upper GI bleed due to cirrhosis and spontaneous bacterial peritonitis is there, the evidence showing that yeah, obviously the first part is okay, that whenever there is a severe upper GI bleed, you have to take control of the airway, so intubation is must. And the second part is the ideal treatment is early endoscopic management. If endoscopy is not available, then you have to stop bleeding. To stop bleeding by Blackmore tube, it is just causing the pressure hemostasis, and because this patient having the variceal bleed and having the ascites and cirrhosis, so spontaneous bacterial peritonitis may be there. So it has showing that if you use this broad spectrum antibiotic in a upper GI bleed where it is a variceal bleeding, then the mortality benefit is there. So what is now what is spontaneous bacterial peritonitis? Spontaneous bacterial peritonitis is that the infection of the ascitic fluid without intra-abdominal surgical treatable source, occurring predominantly in a cirrhosis with portal hypertension. Pathophysiology, bacterial translocation, usually it is hypothetically bacterial translocation from the gut lumen, mesenteric lymph node, bloodstream, ascites. Contributing factor, low ascitic fluid protein, impaired optimization, gut diabetes, and immunodysfunction in the cirrhosis. Usual microbes are the gram-negative enteric organism, E. coli, Klebsiella, commonest, gram-positives, Streptococcus species or Enterococcus, ESBL is more common. Clinical presentation, fever, abdominal pain, tenderness, unexplained encephalopathy, AKI, hypotension, may be asymptomatic, hence low threshold for pancreatitis. Diagnostic criteria, your you have to do paracentesis and uh, your the neutrophil count should be more than 250. Then it is a spontaneous bacterial peritonitis, and there is a another criteria is the one is the classic SBP is your polymorphonuclear cell, means neutrophil is more than 250, or secondary peritonitis is and CT, your management is empiric antibiotic. Commonly, you have to give the broad spectrum antibiotic, which can cover the your Enterobacteriaceae and piperacillin tazobactam or carbapenem plus vancomycin is the choice. You have to give the albumin. One in spontaneous bacterial peritonitis, albumin is one of the key factor, and paracentesis you have to do. And what you will monitor the repeat paracentesis after 48 hours. If no clinical improvement expected, your neutrophil count reduced to more than 25%. Prognosis in hospital mortality 10 to 20%, first year recurrence 70%, and SBP is the marker for advanced cirrhosis and early transplant evaluation you have to do. Another important question may come from this areas here in GI in EDIC, that is your hepatorenal syndrome. It is very popular hot topic for part 1 exam. You might get question from the hepatorenal syndrome. Now next question is 30 years old lady, history of depression, is brought to the emergency department by emergency medical service for lethargy and confusion. She was last seen family about 6 hours ago. Emergency medical service personnel had found an empty bottle of acetaminophen in the site from where she was rescued. On examinations, her Glasgow coma scale score is 11, but she is hypotensive. She required 2-liter bolus IV fluid to stabilize her blood pressure, and laboratory results showing that AST 57, ALT 34, LP is 115, albumin 3.6, INR 1.1, serum lactate is 1.1, and arterial blood gas analysis pH is 7.31, and PaCO2 is 37, PO2 is 93, acetaminophen level is high 375 milligram per dl. ECG showing normal sinus rhythm. Which one of the following is the most pertinent next step of management lady condition? So paracetamol poisoning, acute liver failure is another key area for part 1 exam. The option observation, vasopressor, N-acetylcysteine, naloxone, and intubation. So please give answer. Yeah. I think everybody is Very catchy question. So, paracetamol poisoning, the antidote is N-acetylcysteine. N-acetylcysteine. Why N-acetylcysteine? When the paracetamol is metabolized in the liver, it it metabolized in the liver by oxidation, and it produces the uh, non toxic metabolite. But when the glutathione depletion in the liver, it produces the N-acetyl P-benzoquinamine, which is hepatotoxic, and it causes hepatocellular necrosis and ultimately cause acute hepatic failure. So the NAC, how NAC is act? NAC is replenish the depleted glutathione, so enhance the non-toxic metabolite of the acetaminophen, and therefore it reduces the liver necrosis. And also NAC is recommended for non-acetaminophen uh, hepatotoxicity due to hepatitis and other causes. So now question number 16. 55-year-old gentleman with a history of liver cirrhosis secondary to hepatitis C. Alcohol excess admitted with ICU with profound hypotension. He had been thoroughly assessed in the emergency department after having progressive worsening of the abdominal pain, fever for past 4 days. He he is in a severe respiratory distress, is intubated. His blood pressure is 80 by 45. In spite of adequate fluid resuscitation, central venous line is placed, following which he started vasopressure. Spontaneous bacterial peritonitis is suspected. Diagnostic pancreatitis is pancreatitis is paper, following which peritoneal fluid is sent for analysis. Regarding spontaneous bacterial peritonitis, which one of the following statement is correct? Option: blood culture is not needed in a patient with spontaneous bacterial peritonitis. Fresh frozen plasma should be given when the INR is 1.7 to avoid hemorrhagic complication. Renal failure is not independent predictor mortality of patient with SBP. The most common SBP organism, E. coli and Streptococcus pneumoniae. The diagnosis of SBP can be confirmed by white cell count more than 400, polymorphonuclear leukocyte 80%, red blood cell count is 2000. So, answer please. D. Yes, let's see. Diagnosis confirm white cell count more than 400, polymorphonucleoside 80%. Yes. So bacterial translocation is the key mechanism of spontaneous bacterial peritonitis. Diagnosis is more than 250 polymorphonuclear leukocyte, ascitic fluid, and the most common organism is E. coli and the Klebsiella, not E. coli and streptopneumonia. So, broad spectrum antibiotic, you have to cover the both the gram negative organism, and your if the INR is if there is a no bleeding complication, you should not give fresh frozen plasma, and blood culture always needed for spontaneous bacterial peritonitis cases. Now coming to the question number 17. 61-year-old lady with a history of severe triple vessel coronary artery disease underwent coronary artery bypass grafting surgery 3 weeks ago, and she brought to the emergency department with fatigue and melena. She is evaluated thoroughly and started pantoprazole infusion, and esophagoduodenoscopy revealed a duodenal ulcer with two large vessels visible, which are clipped and injected epinephrine. 6 hours later, there is a three large maroon color bowel movement with clot. She underwent urgent transcatheter arterial embolization of gastroduodenal artery. Her hemoglobin remains stable 8.5 gram per dl. Next day is further episode of the melena and complete blood count reveal hemoglobin fall to 5.7. Which one of the following the first line management to control her symptom? This is your option, and please give your answer. So repeat T, consult surgery, restart proton pump inhibitor, perform bleeding scan, repeat endoscopy. Yeah. So again, there is a mixed type of answer. So the exact answer is repeat transcatheter arterial embolization. Why? So multiple study demonstrates that transcatheter arterial embolization is the appropriate intervention after initial endoscopic pain control bleeding.
अच्छा उसी लेडी को
Fatma,
Patient, load is now 5 non-reacting.
Fat,
Even before 5 non-reacting, 4 sluggish. Now both the non-reacting 5.
excuse me, Fatma is there. Okay. So next question is 29-year-old Primi Gavida at 35-week period of gestation admitted in the ICU with altered mental status and the jaundice and abdominal ultrasound scan reveal fatty liver. Which of the following is the most pertinent therapeutic intervention as this stage or pregnancy? Magnesium sulfate, delivery of the fetus, ursodeoxycholic, and cholestyramine. Actually, this is a question directly not GI related, but due to the fatty liver, so I put in this segment. So, what is your answer? Okay, let's see the option. Delivery of the fetus. It is a question of the is a preeclampsia, the HELP syndrome, or fatty liver. The treatment of choice is first delivery of the fetus. Now coming to 45-year-old lady who was previously fit, healthy, presented emergency department, complaint of hematemesis, and he has no history with the suggestive of liver disease with gastric or esophageal varices. Nasogastric tube is placed, bright red aspirate, but there is not clear with 500 ml lavage. The provide diagnostic endoscopy is pending. Which one of the following is the first step of management lady condition? Administration of fresh frozen plasma, administration of sucralfate H2 blocker, and continuous infusion of the vasopressin, continuous infusion of the proton pump inhibitor, and continuous infusion of the H2 blocker. So please give your answer. Okay. So continuous infusion of the proton pump inhibitor is the answer, because it is not variceal bleeding, it is a your trace ulcer or Mallory-Weiss syndrome. So peptic ulcer is the most frequently cause of acute upper gastrointestinal tract bleeding in hospitalized patient. Proton pump inhibitor frequently used part of initial management. Compared with either placebo or H2 blocker, proton pump inhibitor treatment significantly reduce rate of ulcer rebleeding and surgical intervention. Meta-analysis randomized controlled trial proton pump inhibitor treatment for ulcer bleeding found no significant effect of 30-day all-cause mortality, which was predominantly primary endpoint of the clinical trial. Initially, treatment before endoscopy decreased the stigma of bleeding seen in endoscopy, but no effect on the bleeding. Transfusion requirement needs surgery on mortality. So, the recent evidence says that if you continue proton pump inhibitor, it reduces mortality followed by endoscopic treatment. And all patient bleeding peptic ulcers should be tested for Helicobacter pylori and treated with present proper follow-up confirm the eradication. Now the last question of today's class is 53-year-old gentleman with 1 week history of nausea, vomiting attended emergency department for evaluation. He had a bariatric surgery 3 months ago and he reported generalized weakness, fatigue, confusion, weakness, bilateral lower limb associated with numbness, both hand and feet, blurry vision. Physical examination shows sinus tachycardia, horizontal nystagmus, peripheral neuropathy, muscle weakness, decreased reflex. View of above presentation, which of the following is the opposite next step management is symptom? IV thiamine, IV immunoglobulin, systemic steroid, and IV antibiotic. Option A, B, burst. So IV immunoglobulin, why immunoglobulin? Why systemic steroid? So IV thiamine, why? The thiamine deficiency is rare and most cause depletion of the vitamin B store. People may become deficiency of thiamine by not ingestion enough vitamin B in the diet, though body excess use. The latter may result from hyperthyroidism, pregnancy, lactation, and fever. Thiamine deficiency can occur after bariatric surgery with nervous system involvement. It is called dry beriberi. Neurologic finding can be peripheral neuropathy characterized by symmetrical impairment of the sensory motor reflex function of the extremity, especially in the distal lower limb. The peripheral neuropathy thiamine deficiency may also present in the subacute motor axonal neuropathy mimicking Guillain-Barré syndrome. Another presentation of the neurologic improvement in the Wernicke encephalopathy, in which orderly sequence symptoms occur, including vomiting, horizontal nystagmus, pulses of the eye movement, fever, ataxia, progressive mental impairment leading to Korsakoff syndrome. Prognosis is a good since condition mostly respond with the thiamine replacement. So thank you guys. Actually, in the GI, there are few area which is very important, you may call hot topic in the GI system. One is the upper GI bleeding. You will get lot of question from the upper GI bleeding, and especially they prefer that the sex uh, the difference between your Sangster tube or Blackmore tube, and also the endoscopic management and spontaneous bacterial peritonitis, other area, hepatorenal syndrome, and paracetamol poisoning, acute liver failure, then obviously pancreatitis and the spontaneous bacterial peritonitis. These are the area where MCQs come. So please go thoroughly this area. At least you cover the WOS manual, which is the golden book for part 1. You will get lot of question from there, and follow the Washington manual also. In K-type question, you will get lines from the Washington manual. So best of luck from my side. And next month I will take, next month means the end of this month, I will take mock test on respiratory system, and in February renal and your neuro. So I will cover monthly 2 areas by through mock test. So thank you. Good night. If you have any question, you can ask me. Sana, when is opening the registration?
Sir, it is on 13th January.
Okay. So usually they give CET time. CET is the Central European time. 13 January 9 a.m. They will open the office, and you have to check the what will be the time in India. So, or in your place, what is the exact time according to CET 9 a.m. So it is better you log early, otherwise you will not get the seat. So part 1 is not so difficult to get the seat, but part 2 has a within 1 hour the every seat is blocked. They have only 200 seat, and part 1 maybe the little higher seat, so you might not face the problem. But if you delay 24 hours, you will not get seat definitely. So everybody please log in the esicm.org site and create your account there, so it will be easy to get the registration. Otherwise you will not. If you are not member with ICM, yes ICM, then you get the membership, because membership fees is around 110 euros, but it will save your 150 euros in the exam fees. And also you will get lot of thing from the ESICM, the academic support, and also the journal, the every review article in the journal is the topic for questions. So definitely you go through this journal. Thank you all. And if you have any particular question, you can switch on your Zoom and you can ask me. Thank you. Good night.